So for breast cancer patients out there, you've been offered an implant reconstruction, or you're just doing reading about your options and you come across these terms: pre-pectoral, sub-pectoral, sub-muscular, sub-glandular. You come across these terms that are describing where the implant is sitting in the chest wall in relation to the pectoralis muscle, which is the chest muscle that we use for chest presses and push-ups. So let's talk about the pros and cons of doing a pre-pectoral and a sub-pectoral reconstruction. So let me first describe what those terms mean. So pre-pectoral means the implant is placed in front of the pectoralis major muscle. A sub-pectoral reconstruction or a sub-pectoral implant placement means the implant is placed behind the pectoralis muscle. I'll say, first of all, both are totally legitimate ways of doing breast reconstruction. And I personally do both, and I've trained with lots of surgeons who do both techniques as well. So both are completely acceptable ways of doing it. And some plastic surgeons tend to favor one method of reconstruction compared to the other. So in general, if your surgeon strongly recommends one over the other, they probably have good reason for doing it. But let me tell you a bit about some of the pros and cons of the two of them and why a surgeon might recommend one technique versus the other. So a sub-pectoral reconstruction, so the implant being behind the muscle, is actually sort of the more classic way of doing an implant reconstruction. And the thought behind that is that when you have a mastectomy, the breast gland is gone. So you have a pocket or a space, like a skin envelope. So you have your skin plus minus the nipple that's still there, and there's that space that needs to be filled with something. The skin blood supply is very challenged by a mastectomy because a lot of the skin of the breast gets its blood supply through the breast gland. When you remove the breast gland, the skin has to get blood supply from itself right away in order to survive. So if the skin layer is really thin, it's not going to support the implant well, and also we worry about the wound opening or the skin not healing properly. So with those risks in mind, a lot of surgeons 10, 15 years ago, almost everyone was doing a reconstruction behind the muscle because the muscle gives a separate layer of blood supply and a good, robust layer of tissue that can protect the implant so that it's less likely to get exposed, or if there's a wound healing problem, there's an extra layer of protection on top of the implant. So a sub-pectoral reconstruction, though, does have that advantage. Another advantage that it has is that extra layer of tissue acts like a little buffer. So again, when you have a mastectomy, you don't have the breast gland anymore. So in some people, if you have an implant in place, you see a very sharp transition between where the chest wall ends and the breast starts. So if you have a layer of muscle on top, sometimes the top part of the breast, which we call the superior pole, it's much smoother. So that is another advantage of an implant behind the muscle, especially in really skinny patients. If they don't have a lot of tissue there, that extra layer of bulk for the muscle helps the implant just sit more naturally and look smoother. Let's talk about disadvantages of subpectoral implants. One of them is the patient can get what's called an animation change or an animation deformity. So when they activate their pec muscle, so for example, they do chest press, push up, or they just contract their pecs, the implant will move. And then when they relax, the implant moves again. It's not really in most patients, it's not really a big medical complication or a big medical concern, but it can certainly affect the aesthetics of the breast. Fortunately, very severe and unsightly animation changes or animation deformities I find is pretty uncommon, but every now and then you have a patient in whom it really bothers them. So placing the implant in front of the muscle, let's talk about that, a pre-pectoral implant placement. Some advantages. One is that you don't have to worry about that animation change. The healing or the downtime or the pain after surgery theoretically is less because you're not surgically dissecting that pectoralis muscle. So there's less tissue being cut, so theoretically it's not going to be as painful after surgery. A pre-pectoral reconstruction, though, does have a few disadvantages. One of the most common ones that I see is you see rippling more. So what do I mean by that? All implants will ripple to some degree. So this is a silicone gel implant. You can see when I have it on its side, there's some rippling. In a patient that's had a mastectomy, the layer on top of the implant, and especially in a pre-pectoral reconstruction, is very thin. So you're more likely to see that rippling. And again, it's not really a medical problem per se, but some patients are really bothered by the aesthetics of that. And it ripples more because there's just less tissue covering it. Sometimes you can see the transition between the chest wall and the implant much more starkly with an with a pre-pectoral reconstruction, because there's just less tissue sort of buffering the sides of it. In general, my approach, and again, each surgeon will have their own approach, unless my patient feels very strongly when they come see me about wanting a pre-pectoral or a sub-pectoral reconstruction, I generally tell them that I make the decision during the operation. So when the general surgeon has done the reconstruction and I scrub it and I come in, I'm going to put in the implant, I'll assess the skin. Is the skin thick? Is it thin? Does it look like there's an issue with blood supply? Is the skin flap even? Is it uneven? So the skin flap is thin. If I'm worried that there's going to be issue of blood supply, then I'll put the implant below the muscle, because then I want that extra layer of protection, providing the blood supply and the good coverage for the implant. And then I don't have to worry about any little nooks and crannies if the skin envelope is really, really thin. If the skin flap is nice and thick and I'm not worried about the blood supply, then I tend to put the implant in front of the muscle. So in summary, I do both. I probably do about 50-50 of each. And I will say this too, whether it goes pre or sub-pectoral, these little trends in plastic surgeries tend to fall in favor and out of favor. Right now, pre-pectoral reconstruction is what a lot of people are talking about. There's a lot of buzz about it, but who knows in the next 5, 10, 15 years if we'll all revert back to doing a sub-pectoral reconstruction. So my advice is you talk to your plastic surgeon about what goals are important to you. If any of those complications, if you have them, if they would really bother you. So if the idea of rippling really bothers you, then you probably should go sub-pectoral. Or if the idea of having an animation change really bothers you because you're someone who likes to work out a lot at the gym and do a lot of chest exercises, then you probably go pre-pectoral. So talk to a surgeon who has experience in these, ideally someone who does both methods of reconstruction. They can let you know what's best for you.